surgeons in the country practicing in Hyderabad, the one who's led our way in diabetic surgery, particularly ileal interposition. And we've learned a lot from him. Dr. Suren, welcome to the meeting and for this moderation of this session, important session of expert talks. Next, we have Dr. Shashank Shah, who again requires absolutely no introduction. He's been a pioneer bariatric surgeon in the country, president of OSI. Presently, he's a trustee in OSSI, practicing in Pune and Mumbai. In fact, practicing all over the country. So, welcome, Dr. Shashank, as well. So, we'll start with the first talk, which is from Dr. Kamal Mahavar, who again is somebody we know very well, who's been actually publishing one paper a month and practicing. He had a lot of surgeries lined up. He practices in the UK. So he's recorded his presentation. So so if you can tell So we'll start with his presentation, and what I would request the moderators is, once he's done with it, please you can discuss his talk after that. Thank you.
Okay. Thanks.
Count down कर रहा हूँ, ठीक है सर? 3, 2, 1.
So Dr. Mahavar is a very well-known and academic.
Hello, good morning, everybody.
Thanks.
My name is Kamal Mahavar. I'm one of the consultant surgeons from Sunderland in northeast of England, and I wanted to be virtually there with you when this session was taking place, but as I said earlier, it's just somehow clashing with my theatre commitments, so I can't be there with you at the same time. So I have requested Dr. Goyal and team to kindly record this and then play it in my absence. My apologies in advance for that. This is just really an unusual time in many respects for all of us, and I'm sorry for this. But having said that, I'm honored to be amongst you, though virtually and though in absence. And congratulations to the organizers for organizing this India-UK Surgicon, and I'm proud and humbled to be a part of it. So the topic that I was given is does the choice of procedure have any impact on weight loss outcomes with bariatric surgery? And I have slightly expanded that to also include metabolic outcomes. And I know that I've got approximately 15 minutes to talk about this, so I'll try and stick to my time. So let me see if I can move the slides now. Okay, so what are the choices? In terms of the choices, the latest data that we have is from IFSO 2016 survey of national societies published by Anglisani et al. In 2018. And that basically showed us that gastric bands are on their way out. BPDDS never really took off. Sleeve gastrectomy has become the commonest procedure in the world, and I think it is probably even more common now. The Roux-en-Y gastric bypasses were declining, and the 1 anastomosis gastric bypasses were rising. And to that, I made these extra black arrows that you will see. This is my extrapolation. And obviously, this may or may not be happening, but my extrapolation is that around about now, 2020-ish, or in near future, 1 anastomosis will take over Roux-en-Y gastric bypass. That may not happen partly because of the ASMBS position on OAGB, because we're not letting things take their natural course, but still I think OAGB will be a dominant contender to the RYGB's position in near future. Let me see how to move that. In terms of the primary options, and I think we're only talking about primary surgery options here, because revisional surgery options is a can of worms, really. What are the options that people have? So really, I think we really have 3 main options. And for North American colleagues, there are only 2 really main options: sleeve gastrectomy and Roux-en-Y gastric bypass. But the vast majority of the audience of this talk will be either Indian or British surgeons. And I think we in both countries, we're doing 1 anastomosis gastric bypass as well. So there's really a third option for us too. PPD and gastric bands, I think we don't need to talk about them much because they are not being commonly used as primary options anymore. So coming to the comparisons between sleeve gastrectomy and Roux-en-Y gastric bypass, and if you only focus on the randomized studies, individually, those studies were not showing significant difference in weight loss at 5-year mark. So what we did, Alistair Sharples and I, we conducted a meta-analysis of the outcomes comparing the two procedures at 5 years of this meta-analysis of randomized studies only. And you can see that very clearly we showed a significant, statistically significant difference at 5 years in terms of excess weight loss between Roux-en-Y gastric bypass and sleeve gastrectomy. We saw 65.7% with Roux-en-Y gastric bypass in all the randomized studies included in this analysis, compared to 57.3% with sleeve gastrectomy at 5 years. Now, even if you look at the 57.3% excess weight loss with sleeve at 5 years, that's not bad at all. And even though there is statistically significant inferiority compared to Roux-en-Y, I think clinically that is a really good outcome compared to non-surgical weight loss procedures. So then, one wants to identify, are there any cohorts of sleeve patients who actually particularly do better? And this I know from my own experience as well as that of published experience, and I'm going to cite 1 or 2 studies, that generally it seems like higher the BMI, the outcomes of sleeve gastrectomy then tend to be less and less satisfactory. And I've quoted 2 studies here, you can find many more. And generally, my interpretation of this, data, the randomized studies, the meta-analysis and other studies is that sleeve gastrectomy is a good option for those with lesser burden of obesity. And in my opinion, that cutoff is somewhere in the region of 45 to 50 kilograms per meter square BMI. And as you go higher up, sleeve gastrectomy is then not a very good option because it's still, even after the weight loss with surgery, you're still leaving patient with a significant burden of disease. So then you're really committing patient to something else at the second stage. And we know that even second stage surgeries are not really, straightforward because there are many options there and not all of them work consistently. And some of them may have a fair number of side effects as well. So if you're only looking at one procedure for a patient, then probably sleeve gastrectomy may not be a great option for those with BMI 45 to 50 plus. Then you look at, the other 2 procedures that we talked about, Roux-en-Y and the one anastomosis gastric bypass, and the strongest data on that comes from the French multi-center RCT. And this RCT, we'll talk later about the limb length because the limb length for OAGB was 200 centimeters, and authors therefore showed more complications, more nutritional complications with the OAGB. But more importantly, sticking to the weight loss, these authors showed that at 2 years, excess weight loss in the 2 groups was similar. They called it non-inferior because that was the trial design. But if you look at it, mean percentage excess BMI loss at 2 years, 85.8% in RYGB group and nearly 88% in OAGB group. And the total percentage weight loss was similar as well. So really, not much difference there. And OAGB is as good as RYGB. And we also knew this from other RCTs in the past, because we know the Annals RCT published by Lee in 2005. I know it was not adequately powered and it had some of the weaknesses, but still, it showed that at 1 year, there was significantly better excess weight loss with OAGB, even in a small number of patients. And at 2 years, the numbers did not reach statistical significance, but still slightly higher weight loss with OAGB. So my reading is that, OAGB is probably as effective as RYGB in terms of weight loss, at least in the early phase. And then we have this RCT from Om Tatia's team in Kolkata, where they compared OAGB to sleeve gastrectomy. And once again, though they did not show any statistically significant difference, we can see that OAGB was doing slightly better compared to sleeve gastrectomy at 1 year mark. And we will show you some more data regarding what happens in the longer term. It is important to clarify here the limb length issue with OAGB because, we know that OAGB 200 centimeters, results in some patients needing surgical revision for protein calorie malnutrition. And we know that some patients have also lost their life with 200 centimeters and longer limb lengths. Hence, we had proposed in Sunderland quite a few years ago that 150 centimeters should be the benchmark length for this procedure. And that was initially met with skepticism because surgeons felt that this would lead to then they compromise the efficacy of the operation. But that turned out not to be the case because we published our data last year and we have shown that the excess weight loss with OAGB 150 at 74% is similar to what you see with OAGB 200 centimeters. And of course, this is a randomized, this is not a randomized study, this is a retrospective case-controlled study, and obviously it has got its own weaknesses. But the same numbers are being shown by colleagues from around the world. And more recently, there's been a good French paper by Liagre et al. Published in Obesity Surgery that I would recommend you read if you were interested in this area. The other important study was actually published from the Indian Bariatric Surgery Outcome Reporting Group, which was led by Sarfaraz Baig, my friend in Kolkata. And he showed quite significantly there that at 1 year, there was not much difference in terms of excess weight loss, because with sleeve, actually, you got slightly more weight loss. You got 70%. With Roux-en-Y, you got 64%. With OAGB, 72%. Much the same, really. But the real difference became at 5 years. At 5 years, the weight regain was so much in sleeve gastrectomy patients that they actually came down to the bottom of the pile at 57%, then 60% with Roux-en-Y, and the weight regain was least with OAGB, and the excess weight loss was 70% in those patients. And once again, we have to bear in mind that because most of these patients would have had an OAGB BP limb length of 200 centimeters, this data cannot be directly extrapolated to 150 centimeter OAGB, but my hunch would be that this would probably be the same for that limb length as well. Hence, my interpretation and my own personal experience is that one anastomosis gastric bypass with 150 centimeter BP limb is as good as Roux-en-Y gastric bypass and probably superior to sleeve gastrectomy in terms of weight loss. One more thing we know, and which is, I think, almost a fact, is that it's definitely easier because I perform all these 3 operations and know it for a fact that OAGB is easier compared to Roux-en-Y gastric bypass. Even in a surgeon like me who does not do very high volumes, we do between 50 to 100 procedures each surgeon in the team every year. And hence, I think for patients with a BMI of more than 45 to 50, OAGB is easier, and hence my preferred option, because what is easier for me is safer for patients, I often tell them. So coming to the metabolic outcomes, because as I said, I'm not going to just restrict myself to weight loss outcomes. We don't just do bariatric surgery for weight loss, we also do it for metabolic outcomes. So what is happening there? So in the same meta-analysis that I talked about that Alistair Sharples and I performed, though there was no statistically significant difference, we found that resolution of type 2 diabetes was happening more commonly with Roux-en-Y gastric bypass at 5 years at 37.4% compared to 27.55% of sleeve gastrectomy. Now, because these studies were not powered to evaluate difference in diabetes resolution, this difference did not reach statistical significance in this meta-analysis. But that should not detract us from the fact that this difference is there. And I think it's quite important. Similarly, in the Omega trial, which again was powered to calculate weight loss, and it was a non-inferiority trial, what did we see? We saw that 60% of diabetic patients underwent complete remission with OAGB compared to 38% with Roux-en-Y gastric bypass, and the partial remission rates were 10% and 6% respectively. There was no significant difference again between the groups, but the authors themselves suggested that there was a potential for type 2 error due to small number of diabetic patients in the study, because the study was not powered to evaluate difference in diabetes resolution. So what I'm trying to tell you here is that on the basis of this randomized data, and I could quote you studies after studies, it would appear that OAGB is superior in terms of metabolic outcomes to RYGB. And there's an elegant study from Himpens and colleagues here, which I would recommend if you had time to find out and study, which shows that whatever the BP limb length, if you put in a Roux limb, which in this study was something like 60 centimeters, just placing a Roux limb tapers the incretin effect, and it makes the procedure metabolically inferior. Now, I know that placing a Roux limb has significant anti-reflux properties. And it is a great tool for controlling reflux for patients who suffer from it, and for patients who may suffer from it as a prophylaxis for reflux. But it is anti-metabolic, and Rulimb tapers the incretin effect. And this is a very powerful study. And also in terms of comparing the metabolic outcomes with sleeve gastrectomy, we have data from Lee, which is randomized data, a small number of patients, but once again showing that at 5 years, 18 participants in the OAGB group out of 30, and 9 in the sleeve group out of 30 achieved the endpoints, which was HbA1c less than 6.5% without glycemic agents. So basically what we're seeing here, and this is what authors concluded as well, that OAGB group had a higher incretin effect than the sleeve gastrectomy group at 5 years. So my interpretation of this is that one anastomosis gastric bypass has got superior metabolic properties than either of Roux-en-Y gastric bypass or sleeve gastrectomy. It is therefore my preferred procedure for patients on insulin. I personally think sleeve gastrectomy is probably not adequate for those patients because the vast majority of those patients still stay on insulin in the long term. But once again, I am not aware of any strong data to confirm or refute my hypothesis. So what you might then ask is difference between the Roux-en-Y gastric bypass and one anastomosis gastric bypass in my view or generally. So my view is that OAGB is safer and easier. There's no doubt that OAGB is associated with approximately 10 to 15% patients suffering from reflux, acid or bile, whichever way you look at it in the long term. And approximately 1 to 5% patients end up needing some sort of further surgery for reflux, i.e. in my hands, conversion to Roux-en-Y configuration. I leave the GJ intact, just measure an elementary limb of 50 centimeters and do a second anastomosis, divide the omega loop. But in terms of trade-off, it does have a lower risk of internal hernia and chronic abdominal pain. And that, in my opinion, makes it a more attractive option because the complication of OAGB, I can sort out on an elective list, during the cold light of the day, whereas internal hernias and chronic abdominal pain can be difficult to look after. So that is how I take these two procedures. Now, whatever I've just shared with you today, my thoughts on procedures and the weight loss differences and metabolic outcome differences that we have been able to summarize in the form of an algorithm that Dr. Anmol Ahuja from New Delhi, from Gangaram, and I worked on, and we published that recently as well. If you want a copy of it, we'll be very happy to share that with you. So to conclude, ladies and gentlemen, one anastomosis gastric bypass is my preferred option for patients with a body mass index of 45 to 50 and above, and those patients who are requiring insulin. Sleeve gastrectomy is my preferred option for all the others. I don't normally recommend Roux-en-Y gastric bypass as a primary option for patients, for the vast majority of my patients anymore. I think it is a great tool for revision for patients developing reflux after sleeve or OAGB, and for some patients, as I show in the algorithm, with significant GORD preoperatively. So with that, I'll conclude my talk. I hope I've stuck to my time. Thank you very much for listening to me. I will try and join you on the day, but I do have a couple of major cases scheduled on the morning, so I may not be, and if I can't, my advance apologies. Thank you very much for
Dr. Suren, please unmute yourself.
Yeah, so that was a nice talk by Dr. Mahavar, who is known to give balanced views and, as I mentioned earlier, does a lot of academic work with sensible outputs. Are there any questions? I don't see any questions in the Q&A or the chat. So
can I question both of you?
Of course.
So placing Rulimb as an anti-metabolic effect. Your comments, please. Placing the Rulimb as an anti-metabolic effect.
Yeah, go ahead, Shashank.
I think more research probably will need to be conducted for this before we could comment. There's only one OGTT from Jack and Prince. However, I do not see that difference in my clinical practice or on my earlier trials, but it may have a point. A long elementary limb sometimes definitely can absorb some sugars, even though there is a conflict on whether carbohydrates are absorbed in the alimentary limb. And in MGB, probably that is missing, so there is no absorption of sugar. It's directly into the jejunum, like Rowan-Weiss Y or the anastomosis. However, whether it is responsible for anti-metabolic effect, and I would probably wait for more studies and more convincing studies. So, in your opinion?
I would think that since the rule limb forms a part of the total alimentary limb length, it should not actually matter much for an anti-metabolic effect, because for anti-metabolic effect, yeah, the longer BP length, limb lengths are more responsible. It is a fact that the closer you get the ileum closer to the gastric anastomosis, the more of an anti-metabolic effect you are going to have, a metabolic effect you're going to have. So I think that's a controversial area.
He did balance everything. He did say, OAGB only for patients with BMI 40 to 50 and on insulin, and sleep for all the rest is what Kamal mentioned. And he reserved gastric bypass for patients with reflux or revision. I think that was a reasonable conclusion, I believe. He combined all the three procedures, even though his presentation focused more on OAGB.
That's right, and he more or less excluded RYTP from his primary option, which till this date, I think many surgeons, including you, Shashank, and Randeep, probably use RYGB as the primary option.
Yes.
Am I right?
For those with reflux.
Absolutely.
More for those with reflux, more for those who are on insulin.
Yeah. But would you do more of an OAGB instead of RYGB for those on insulin?
So, yeah, please, Dr. Shashank, please go ahead.
Yes. So it is based on probably when we want a stronger malabsorptive option, maybe because of any reason, diet or BMI, fatty liver, dyslipidemia, maybe. If I want to be stronger in malabsorption, I would choose OAGB. But if I want an anti-reflux procedure, I would prefer an RYGB. So symptomatology and gastroscopy, which will lead me to my decision.
Randeep, what is your preference? You still prefer the RYGB? And
So I quite agree with what Dr. Shashank is saying. Yes, RYGB for diabetes, in any case, we would prefer not to do the sleeve as far as possible. Our choices would be between one of the bypasses. But yes, off late, we've been doing a lot of OAGBs as well, particularly if the patient does not have any symptoms of GERD and super obese. We prefer to do a OAGB, like Mahavar also said, that turns out to be a simpler procedure, particularly in the super obese. But for the rest, yes, our first choice procedure still is RYGB for all our diabetics.
Okay, so to make it more effective, I mean, I use RYGB in a modified way only when there is hiatus hernia, severe GERD. But then I use longer limb lengths after measuring the total small bowel. So I do 100, and then make sure the rest of the small bowel has enough length. And so at least you can bring it on similar lines to an OAGB, nearly on similar lines to an OAGB effect, without the risk of reflux and GERD.
So what we'll do, Suren, is that we'll go to the next talk. Yes. Dr. Kelvin Higa's talk is online, and I mean, that's recorded, and we can discuss that. And Dr. Sandeep has just come back from the OT, so he'll go after that.
Okay.
Yeah. So Dr. Kelvin Higa, please. So
line, you can see a tremendous amount of variance. For any given stoma diameter, the weight regain can be all over the place. So I don't think this represents an indication that the stoma size has anything to do with weight regain, but it just is another variable that may or may not make a difference on an individual patient, but cannot be said it does so for all patients. Why? And this is about the cleanest type of a randomization you can perform. There's absolutely no change in weight loss over 3 years. And important, the size of the pouch size, it only makes a difference when it comes to the occurrence of marginal ulcers. Again, an issue with gastric bypass is this pouch is too big. Well, have marginal ulcers, if you make it small, less ulcers, but this doesn't correlate to weight regain or weight loss at all. In fact, the smaller pouches tend to empty faster and are associated with better eating. What about randomized trials looking at super obese patients? They seem to respond differently than the standard obese patients. And this is standard gastric bypass versus type 2 distalization. And there it doesn't appear to be much in the way of weight changes. Now, this is a type 2 distalization, and this is different than the type 1 distalization that we published on. Type 1 distalization is where we modify the operation to increase the length of the biliopancreatic limb at the expense of the common channel. So it looks more like a duodenal switch type of, or BPD type of configuration. And for the length we chose, it seems to be optimal for our patients. If the Roux-Y is 1 meter, we have a 3 meter common channel, so we have 4 meters altogether, the total alimentary length. And it turns out that we have statistically significant improvement in overall weight maintenance, but really what happens is the metabolic issues do get better, and 100% of our patients have resolved their diabetes at the end of 3 years. But the problem is when you shorten the bowel, what happens is the patients often get vitamin and mineral deficiencies, which may offset the benefits of the meager weight loss, as well as the response of the hyperlipidemia, as well as the diabetes. Now, when we're really looking at the super obese patients who are resilient to treatment, I found that besides medications, really the only conversion that seems to be reliably gives us some switch. You know, converting a gastric bypass to a duodenal switch is one of the most difficult, one of the high options I perform. And generally, I don't do it together again by doing a gastrostomy and a fundectomy, but will not attempt to try to make a nice sleeve gastrectomy. If you do, you can expect at least a 30 to 50% fistula rate. And most people that write about this, you will not know, but when they talk about conversion, the sleeve doesn't look like a sleeve. It's a modified sleeve to preserve the blood supply. Once this is done, we come back and either modify the sleeve and or add the duodenal switch, either as a Roux-Y or as a SADI. Now, in my experience, the SADI, and as a revision, the SADI does not work as well as a traditional Roux-Y bypass, but that's just in a very small number of patients, but it seems to be rather consistent. So the strategy really begins with understanding that obesities are chronic disease as it's just not one disease. The response to a given therapy is highly variable, and we have to get the messaging right. Surgery is not the cure, and medical treatments do work. We can't blame the patients. We can't blame the surgery, not just recreate anatomy. If you have a generally it can be reversed or changed to a gastric bypass. These patients, if they're still around, generally are still obese and sometimes super morbidly obese with no GI issues. But for the ones that are malnourished, either reversal or changing to a gastric bypass works well. The vertical banded gastroplasty, in my opinion, is one of the most satisfying operations to revise because conversion gastric bypass takes care of their reflux and the results are just as good as a primary gastric bypass. Gastric banding, I think you can take to almost anything. Most of the gastric bypass works well. Sleeve gastrectomy, probably not so much unless they've had a good response to the band, don't have reflux, don't have dilated esophagus, and sometimes even going to a duodenal switch for extreme metabolic syndrome. The BPD of the biliopancreatic diversion, it goes to reversal, or you can modify the limb length depending on the nutritional issues and quality of life. The sleeve gastrectomy, if it's reflux, take them to a gastric bypass. If it's for weight, it's DS or modified gastric bypass or 1.5 gastric bypass. For gastric bypass, we only revise gastric bypass for complications and not for weight regain unless the anatomy is bad or the symptoms and the comorbidities are bad enough to warrant a conversion to a duodenal switch, but in multiple stages. So for reoperative interventions, the problem is we really haven't defined the standards of practice, the indications and exclusions, the BMI independent criteria, the long-term follow-up, nor the anatomic construct that is optimal. We haven't even defined what determines what is a success or a failure. And so we have yet to require revisional surgery to undergo the same scientific scrutiny that we apply to primary interventions. And yet, although our mortality and risk for primary operations is very good, with mortality less than 0.2%, complication less than 10%, et cetera, we understand that reoperations have a much higher complication rate and mortality rate, and yet unknown as far as the overall performance. And so the risk-benefit ratio is really not, if we think about it, it's really unethical to offer revision surgery, invasive revision surgery, because we don't know the risk-benefit ratio unless the patients are participating in a study or you plan on publishing the results of how the patients do. And so I think it really is unethical to offer patients randomly just operations because we don't know what we're doing. We don't have guidelines unless it's part of a scientific study. So our solution, we should define the standards. We need to establish the criteria. We have to have mandatory data collection in a low-cost, accessible registry. We want to encourage innovation, but not at the expense of ethical consideration. Thank you very much. Take care. Well, greetings.
Unethical to do revision bariatric surgery.
Yeah, so what I find is that many surgeons are probably trigger happy. So I don't know what, Shashank, what do you follow in your practice? Are you very conservative or are you aggressive?
I think it's a joint decision. It is based on comorbidities, long-term risk, response to pharmacotherapy, and if all the above plus lifestyle change attended, everything fails and the disease is progressive or we see some risks, then maybe revision bariatric and metabolic surgery is an option. And I agree with what Dr. Higa said, that there are no guidelines, and so innovations are necessary, of course, ethical innovations.
I'll give you an example. Only yesterday, a lady, she met me. This is many years after her metabolic surgery, ileal interposition. She said, earlier my A1C used to be 5.2, 5.4. Now it's come to 6.2. Now what do we do? So you see that patients have to be counseled and helped. We need to help them to understand this And we as surgeons, I think, have to really make sure we don't, jump the gun and easily fall in for patients' wishes, which may end up in a lot of trouble and morbidities later on for the patient without too much of gain. So I think a lot of sensibility and mature thinking has to go into redo bariatric surgery. So his points of it being used for any complications or really huge failures or huge weight regains, I think would have a place. What do you say?
He did focus on one more point, is if the anatomy is abnormal, then we should focus on revision.
Yeah.
So that means if the pouch is extremely dilated and then you are unable to treat with pharmacotherapy or other therapies, or if the sleeve is maximally dilated and then you are unable to treat. So if there is progression of comorbidities, failure of pharmacotherapy in presence of anatomical abnormality or complication, probably that could be the right place for revision, even though the long-term results of revision procedures are still not known and we need more data.
So we can take one more question and the last question, because since what we'll do is after this we'll have Professor Sandeep Agarwal's talk, and that's it, and we'll end the session at that. So we can take one more question, and this is he said that a BMI of 35, which can actually with phentermine and topiramate, he can get it down to almost 27. I don't know if that is available. Oral anti-obesity drugs, what we've been using is Orlistat or liraglutide. What is your experience in using these anti-obesity drugs?
I use topiramate. I do use topiramate. There is some herbal equivalent for phentermine. I don't know. It is still not FDA approved, but I use that in combination. It is not as strong as pysimia, but it works. In some patients, it works. And the side effects of this combination are what I have seen in my clinical practice are far less than probably a combination with phentermine as a medication, that is pysimia.
So topiramate, what dose do you use and for how long do you prescribe before you are satisfied whether it's having an effect or not having an effect?
So I start on 25 milligram once a day, switch to 25 milligram twice a day. At the end of a month, if there is a response, we continue. If there is no response, then we have to add another medication. This is what is being followed in my unit. There could be variation. This is most commonly recommended and followed. This dose is probably more than the smallest dose of topiramate in this lowest dose pysimia. But there the dose of phentermine adds the value.
So I think we should go ahead to the next talk.
Yes,
then.
please. Yes,
This was
please.
a very nice and balanced talk by Dr. Higa, who's one of the great pioneers, and I think we should heed his advice very carefully. So next we have Dr. Professor Sandeep Agarwal from All India Institute. Again, very, very academically inclined. He's utilizing all his resources, as I mentioned once to him, to get a lot of publications through, which is great because Indian data needs to be brought out. And after his live surgery this morning, we have a talk on reflux after sleep, evidence-based analysis. Please go ahead, Sandeep.
Yeah, a very good afternoon, Dr. Gale, Dr. Shashank, and Dr. Randeep. Thanks for the introduction, and I'd like to thank Dr. Randeep and Dr. Raman for giving me this opportunity to be a speaker at this prestigious meeting, and I wish them all the best. So I will be talking about reflux after sleep, which is an extremely important issue following sleep gastrectomy. And it's really a big topic to be covered in this much time, but I'll try to do justice that emphasizing a few points which I think are important takeaways from this talk. I have no conflicts of interest to declare. So as we all know that there's a high association of GERD with obesity. roughly 50 to 70% of obese patients have some sort of a gastroesophageal reflux disease. And a meta-analysis showed a LSG. Sleeve has long-term fewer side effects in bypass, but there's a higher incidence of GERD to the tune of 5 times in RYGB. And although the GERD can improve after sleep, but most reports now suggest there is a profound negative effect of sleep on GERD. And the more important problem of a new onset GERD, which can occur in about 8 to 30% of patients. So, it's the Achilles heel of the sleeve. It's one of the most profound problem following sleeve gastrectomy, and we can have worsening of pre-existing GERD or a new onset GERD or Barrett's esophagus even in the absence of symptoms. And how does GERD affect the patient after surgery? Causes impairment of quality of life. They may have nocturnal reflux with almost a continuous PPI intake. They may have mental and emotional problems, sleep disturbances, poor social functioning. A reduced weight loss, which is an important accompaniment of GERD in a lot of cases, and it's probably one of the most common causes of revisional surgery after sleeve gastrectomy. I won't go into much of mechanisms. Suffice to say there are mechanisms which lead to improvement of GERD after sleeve, and there are mechanisms which are causing a worsening of GERD after sleeve. And the factor which cause decreased GERD is weight loss, which causes decreased intra-abdominal pressure, increased gastric emptying, and decreased gastric acid secretion, among others. And the factors which cause increased GERD are increased intraluminal pressure as a result of the narrow sleeve, blunting of angle of His, decreased gastric compliance, and decreased tone of LES. So when this problem came into recognition about 10 years back, there were studies on both sides, and the result was quite equivocal, that whether sleep causes GERD was not very clear, because there were studies which would say sleep improves the reflux, and other studies which say it worsens the reflux, and therefore proper conclusion concerning the effect of sleep and GERD could not be made. Everybody said, oh, it's just, we don't know the answer. Then, go 5 years later, there were more studies on this topic, including one of our own studies published in SOAD. This meta-analysis analyzes 33 studies with more than 8,000 patients, and again the same result. Half of them showing a decrease, slightly more numbers showing an increase in reflux, and overall risk difference is just to the tune of 4.3%. Although there was a slight trend towards an increase in prevalence in most studies, and also the problem of de novo GERD. So now the problem started getting defined a bit better. And then came the long-term endoscopy studies, which have really shown clearly that sleeve is a refluxogenic procedure. There's no doubt about it. The study by Breguet et al., prospective study showing reflux symptoms in 65% patients at 3 to 5 years. And on endoscopy, esophagitis in about 30% of the patients, and a Barrett's in about 5% of the patients clearly shows that sleeve is a refluxogenic procedure. Then there was a spate of studies which showed Barrett's esophagus after sleeve, starting with the Genko, often quoted Genko study, showing the Barrett's esophagus in asymptomatic patient to the tune of 17% at 5 years of follow-up. And this was quite worrying. And following that, there were multiple studies, again, reaffirming that same rate. Look at this slide, about 14 to 18%. Again, some of the recent studies have not really shown that much high incidence. Probably because there's a better understanding of the Barrett's and where to take the biopsy from. So this study for Lallemand from France, showing endoscopic Barrett's in about 5 patients, but there was no histological confirmation. And again, they did not show any patient with erosive esophagitis. They had roughly about 20% patient with gray A and B esophagitis. So again, this is a mix of results, and we need to really have more studies to look at what is roughly the exact, what is the real incidence of Barrett's after sleep. This is the ongoing study at AIIMS, where we have till now endoscoped about 74 patients at variable degree of follow. Again, endoscopic Barrett's in about 4 patients out of the 74, and only diagnosed in 1 patient with no dysplasia. Although the results are not out, it again shows that incidence may not be as high as 15 to 20% as quoted in the earlier studies. So again, this is a systematic review of these studies, where they included 10 full test studies, including 680 patients, with a pooled prevalence of Barrett's being roughly about 11.6%. And all cases were observed in studies with greater than 3 years of follow-up. No difference in Barrett's based on GERD symptoms. This was another very good study showing endoscopic findings 5 years following sleeve gastrectomy, showing abnormal upper GI findings in about 46% of patients. Again, so this is not low. I mean, so it's a clearly reflux is an important problem. 10 patients had the score of more than 47, and roughly about 30% patients required conversion to bypass based on these findings of Barrett's, severe esophagitis, and 9 patients with persistent GERD, which is altering the quality of life. And this is one of the recent, very recent studies from Mayo Clinic, which has looked at a large endoscopic database of more than 800 patients actually, out of which they've excluded patients who have anatomical problems like stenosis, kinking, twisting. And these were the patients without anatomical problems, more than 500 patients where they did an endoscopy. And after sleeve was roughly 38%, and including severe patients with symptoms who have been endoscoped. So the real percentage is going to be higher in patients who have no symptoms. So roughly the overall sleeve is showing at a follow-up, variable follow-up, clearly a trend towards victory. Again, clearly showing a lower resting LES pressure compared to compared to bypass patients, and then they compared it with the patients who are waiting for surgery in a case-matched way. They compared their symptoms, they compared their BMI, and they found that LES pressures are lower after sleeve than with preoperative patients, and also the distal contractor segment was shorter. So they found some functional changes which are responsible for increased reflux of sleeve, and they said that one must be very mindful while evaluating these patients, and we must have a clear-cut anatomical as well as functional evaluation of patients with suspected GERD before surgery. And another interesting finding was that in spite of their PPI therapy, the endoscopic erosive esophagitis was present. So PPI therapy did not help in improving the esophagitis. So what are the why so much variability? The problem with the GERD studies is the definition of GERD, which is variable, and some people have used only questionnaires or scintigraphic studies or endoscopy, but very few studies have looked at high resolution manometry and 24-hour pH, and that's why there is so much of variability of results. Besides the change in technique, there's a lack of standardized technique of sleep. The bougie size varies, the duration of follow-up varies, and the variable BMI patients. So let's look at why does this happen. Now, so decreased stomach distensibility, decreased stomach serum ghrelin levels. Sometimes you can have mild gastric stenosis, formation of neofundus. Loss of angle of His is an important mechanism. I think among these things, the most important thing is the hiatal hernia, which is missed with the intrathoracic sleeve migration and a decreased tone. And these are the anti-reflux barrier and what happens in sleeve. In sleeve, what happens is there's a decrease in overall length of the LES and also a decrease in abdominal length. And moreover, there's a dynamic failure resulting in hypotensive lower esophageal sphincter. So this LES failure, which has been found in sleeve, has come up from the high-resolution manometric studies showing a decrease in pressure from 14 to 10. And almost 85% patients following sleeve had hypotensive LES, which is again important, showing it's an important mechanism of reflux after sleeve. And overall, there's a shortening of total length of high pressure zone to less than 3.5 centimeters. Besides the anatomical failure, there's a dynamic failure as well. There are what is known as transient LES relaxations. These are the period of spontaneous relaxations of LES and diaphragmatic cura, which last roughly for 10 seconds to 60 seconds, and they're not preceded by swallowing. We know that swallowing induces relaxation, but these are not preceded by swallowing. And obese people have higher total TLE-SAR compared to normal weight people. And this is the hypothesis that increase in these relaxations may contribute to GERD. What about angle of His? The acute angle prevents reflux of the contents and positioning of the staple line close to the angle of His, but not exactly at the angle of His. When one should be away from angle of His, not include the esophageal fibers, and that would help in maintaining angle of His and leading to higher LES pressure. This could be an important preventive mechanism. Among the other surgical strategies to prevent post-SG GERD are an aggressive approach towards identification of hiatal hernia with concomitant repair or fundoplication. This is like a point which I strongly believe in. In our own practice, roughly about 25%, that is 1 in 4 patients undergoing sleeve, require a concomitant hiatal hernia repair if you look carefully for it. And The repair means not only hyatoplasty, it means ensuring a 4 centimeters, 3 to 4 centimeters length of esophagus in that abdomen. That's again an important part. It's just not approximating the crura, but also mobilizing the esophagus to ensure a good length of esophagus. Or some people do believe in fundoplication, which I'll just talk about. Avoidance of mid-sleeve stenosis, kink and twisting has been discussed and is well known. The sleeve should generally be widest at the antrum and narrowest at cardia, and narrowing at the antrum increases the girth. And this is a controversial point because now currently some of the people are doing antrum resecting sleeve. But I think the most important point, again, besides hiatus hernia, is avoidance of a too tight a sleeve. So, what is the association of hiatus hernia? We know that it is present in 40% of patients with severe obesity. However, there is a poor correlation of symptoms and the endoscopic findings and the detection of hiatus hernia. In our own experience, intraop detection has proven to be the best way if one is carefully looking for a hiatus hernia. And there are subtle signs like a dimple or a fat going up or a part of fundus going up. So one must carefully look for these signs of subtle hiatus hernia. Why? Because hiatus hernia is flux after sleep. It leads to incomplete removal of fundus, leading to weight regain from 30 millimeters to 8 millimeters in presence of hiatus hernia. And if you look at this study, which has studied the risk factors of BE in roughly about 180 patients, they found hiatus hernia is an odds ratio of more than 1.5 for presence of association with bad esophagus. So again, hiatus hernia is something which you can definitely avoid, definitely repair, and look when there is one thing which can definitely lead to decreased incidence of reflux after sleep. Look at this study from Sorcelli et al. Published way back in SWORD, which showed a complete omission or no occurrence of de novo GERD in a subset of patients who had a hiatus hernia repair. And this corroborates our own experience, which we are going to publish soon, that hiatus hernia repair is a very important risk prevention strategy for preventing GERD. Again, this review by Mahavar et al. Showed concomitant hiatus hernia is safe and leads to acceptable post-op GERD rates. However, it is challenging and requires some amount of experience. However, again, this study, looking at about more than 4,000 patients with concomitant hiatus hernia repair, clearly showed that there is no increased risk of hiatus hernia repair if done by experienced people, and almost all other events are comparable in groups with or without hiatus hernia. Which was held in France on GERD and sleep, and 80% surgeons would repair a hiatus hernia even in asymptomatic patients if it was large enough. Large means roughly about 4 centimeters or more, and more than 2/3 surgeons would repair it even if it was small, even asymptomatic. So most of the experts do repair a hiatus hernia repair at the same time. And again, another interesting point was that a lot of surgeons would also do. Most of the experts showing a remission of 88 to 95% of remission of GERD following sleeve and fundoplication. Although we need more studies on this aspect, but this review showed a promising results of sleeve and fundoplication. I will skip this slide. Mesh repair, we don't have much data. There are sleeve and fundoplication. I will skip this slide. Mesh repair, we don't have much data. There are another important thing is the bougie size. If you make a too tight a sleeve using a 32 French or a 30 French bougie, you're bound to have more reflux. Look at this very recent studies published in 2020 from France again, showing prevalence of GERD at 1 year at 76% patients, de novo GERD in more than 60%. These are out of sync with the current literature. De novo GERD is like roughly 30%, 20%. You have a 70% rate, and when I came towards the end of the article, they mentioned we use a 32 French bougie with overswing. So obviously it's a very tight sleeve, and this clearly translates into such a high incidence of reflux. What about antrum preservation? It's a hypothesis that if you preserve the antrum, there's a faster gastric emptying and a lesser intergastric pressure. However, this has not been proven in an RCT by NOCA, which looked at more than 170 patients, and there were the reflux rates at 3 months were comparable. And this is our own data. Again, a randomized study comparing antrum preservation and antrum resection, showing comparable GERD rates at 1 year, roughly 22% in both the groups. And look at the gastric emptying time, that is also comparable. So again, this point is still not, the jury is still out whether antrum resection leads to increased reflux. And obviously we'll follow up our patient for a longer duration to look at that. So a perfect sleeve, I don't know, anybody knows, but the general principles are make it over a large size bougie, that roughly 36 to 40. It should be widest at antrum and narrowest at cardia. Prevent narrowing at mid portion. Preserve antrum. Repair large hiatal hernia more than 4 centimeters, and last staple line should not be at the GE junction but slightly away from it. Treatment options, we all are aware. First treatment is lifestyle changes. I think one must remember that most patients of sleeve reflux do not require operative therapy, and this has been borne out by 2 large RCTs with 5 years follow-up showing the rough rate of conversion of sleeve to bypass to about 6 to 8% with severe GERD. So the first line of therapy remains lifestyle changes and medications. Endoscopic or surgical intervention is the stricture or the stenosis and a conversion to bypass. This is a beautiful table given in one of the articles where again they have looked at failed treatment, failed PPI, and following that they have done functional studies to finally confirm GERD and convert to bypass. This was just a one point I would like to make. This study from Mayo Clinic, which said that in the prevalence of severe erosive esophagitis, PPI therapy may not work, and there are reasons for that because of the functional mechanisms that PPI doesn't work. So indication of conversion remain severe symptoms, erosive esophagitis, volume reflux on barium like in this picture, or the PH studies confirming severe GERD. These are some of the things which require conversion definitely. A stricture, angulation, a twist in the mid part, a sliding herniation of fundus with a paraesophageal component. They all require surgery. And this again, the expert group said that RGYGB is the preferred procedure in post-SG GERD in the following indication. Definitely with Barrett's esophagus, whether with insufficient or sufficient weight loss or with uncontrolled GERD. So this remains a procedure of choice. So just to conclude my talk, chairpersons, reflux out of sleeve is a problem. There's no controversy about it. Long-term studies show significant prevalence of erosive esophagitis and Barrett's esophagus. A careful patient selection preoperatively with functional evaluation and endoscopy and a meticulous operative techniques remains key to lowering these rates. In our own experience, missed hiatal hernia is an important cause of GERD post-SG and requires an aggressive intraoperative approach. Most patients with post-sleeve GERD respond to medical management, although one of the recent papers has shown it doesn't. RYG remains the most effective treatment. And further studies, whatever research we do on GERD should include all the standard diagnostic tools like the high resolution manometry and a 24-hour pH. Without that, I don't think studies make much more sense. And I think this is the most important point when we counsel the patient is that we must explain with occurrence of GERD after sleep cannot be predicted. Extensive patient counseling about this part, GERD, and that they should be informed regarding the variable impact of sleep on GERD. They should be warned of de novo GERD symptoms in the post-operative period, and the need for future surveillance endoscopies at whatever intervals which get defined in future studies may be required in such patients. Thank you for your patient listening.
Very well summarized, Sandeep. And a very, very good review of all these studies.
Thank you.
Still, the number of sleeves in the country are increasing. What do you see the scenario of reflux disease in future, or maybe a role of Roux-en-Y gastric bypass getting installed again? Your comment?
I think as most of the studies have shown that long-term complications of sleeve are definitely lower than bypass. So we have to keep that also in perspective. Second point is, if you look at the Mayo Clinic study, a significant percentage of bypass patients have Barrett's and GERD. It's not that sleeve, Roux-en bypass is free from Barrett's or GERDs. So comparing everything, I think sleeve will remain a popular procedure. I think we need to be careful about the technique. As well as when people talk about Barrett's, I think we need to have very well-defined biopsy protocols. So, biopsy, the protocols are very, very strict if you look at most of the gastroenterology studies. So if you do wrong biopsy in wrong places, we're bound to have a higher prevalence of GERD. That's what Mahavar also wrote in one of the letters to the editor. So I would still say sleeve would remain a very popular procedure, given its low risks over a long term. Plus, absence is not that other procedures don't have reflux.
Thank you, Sandeep. Well summarized. I think there is a request we should switch to the next presentation as soon as possible.
Thank you so much, I think. Thank you.
Can we have Dr. Dino?
Thank you.
So we welcome Lillian Craig-Dino from Florida, USA. It's very early in the morning. Thank you so much for waking up and taking time out for the presentation. Welcome,
My
Dr.
pleasure.
Lillian.
Thank you so much. So can you hear me okay?
Yes, we can hear you and we
Okay.
can see your slides as well.
Wonderful. Thank you so much. I just want to thank Dr. Goel and the organizing committee for inviting me here. I'm very humbled to be representing the dietitians that work with bariatric patients. So thank you so much. This is my disclosure statement, although none of these will affect my talk today. So after this presentation, I'm hoping the delegates will be able to discuss selected nutritional complications after metabolic and bariatric surgery. And we're going to talk about implementing some evidence-based nutrition recommendations to prevent or treat the complication. So I've been in bariatric practice for quite a long time as a nutritionist, and as you can see from this list, I've seen many things throughout the years. The ones highlighted in yellow are the things that we're going to be talking about today, but as you can see, this list has some sort of nutritional implication. So there's really an important role for a dietitian on your team. So let's talk about these today, because this is what I have interest in. We're going to talk a little bit about BZOR and just how common that is actually, changes in bowel habits, micronutrient deficiencies, and protein-calorie malnutrition and sarcopenia. So when a patient presents to the clinic with abdominal pain, there we go. I think they want, there we go, hi. Okay, so when a patient presents in the clinic with abdominal pain, one of my jobs as a dietitian is to determine, is this some sort of dietary reason or is it a reason that I need to go get my surgeon? So oftentimes what we're seeing is we can solve the problem because it is some sort of dietary issue. And one of the things that we see are BZORs. So BZORs are actually more common than you think. When you read the literature, it's up to 29% of patients with bariatric surgery can develop a BZOR. And that means the gastric bypass as well as the sleeve gastrectomy. At one time, we didn't think it would happen in the sleeve. There are different types of BZORs depending upon what material is actually getting stuck. So we've got the phyto BZOR, which is the most popular, the tricho BZOR, which had some sort of psychological implication there, pharmaco-BZOR. You have the diospiral BZOR, which is a very interesting BZOR because it's created specifically by the persimmon fruit, which is a very popular fruit in the Asians. I'm Asian, I eat them all the time. And then this one was interesting. This one was an inorganic fabric BZOR. So I'm not quite sure what the patient was eating here, but as you can see, these can be very, very dangerous. The symptoms would be, they would range anywhere from pain to obstruction to constipation. And I wanted to show you this because this was very interesting. This is something that happened actually at my clinic. This is a 44-year-old female who was discharged with gastric bypass. It was uneventful, but right around day 5, she was experiencing a lot of pain. She wasn't having any bowel movements. And because of that, she decided to take a laxative, one that was polyethylene glycol. And that actually caused a BZOR. And she had to go in for a revision. So we have to be really careful to educate our patients on what is a BZOR and how to present a BZOR and what might be some of the symptoms. So what could be implicated in a BZOR formation? Well, when you look at some of the fruits and vegetables, you know, we dietitians really have to educate our patients to eat slowly, chew very well, and there are certain fruits that are going to have a higher incidence of BZOR formation. Also some medications as well, especially some of the vitamins and minerals. We do have our patients do chewable vitamins, but sometimes they don't want to chew these vitamins. They want to swallow them because it's just easier for them. That could be pretty dangerous in the perioperative stage. So we're always having them do chewables or liquids for about 3 months or so. So what's the treatment? Well, if the bezoar is in the stomach, that can be removed endoscopically, and bezoars in the small bowel usually require surgery. But is there any kind of medical nutrition therapy for bezoar? And what's very interesting is when you read the literature, there is evidence that when you use Coca-Cola, and I'm just using that brand name, that could actually dissolve phytobezoars. Of course, that's not going to be effective for the other types of bezoars. And the other thing that we can do is add different enzymatic enzymes, digestive enzymes, the cellulase, the papain, and doing that in conjunction with the Coca-Cola seems to resolve some of the issues so the patient does not have to go into surgery. So that's always good. The only challenge that we find is that if the patient is, some patients are actually drinking the soda, and of course that's against our dietary recommendations. We're asking them not to drink carbonation. So if they're being treated with carbonation and Coca-Cola for the bezoar, oftentimes they will continue that behavior, unfortunately, and continue to drink the soda. So for bezoar, what is the practice guidance? Well, we have to recognize that history of bariatric surgery in and of itself poses a risk for bezoar formation just because the nature of the surgery, the low stomach acid, the differences in the way the patient has to chew, the differences in the food intake. Strong patient education about what they are and what causes is important. And we need to discuss foods that have a higher risk of developing into bezoars. We need to stress the importance of eating slowly, taking 20 to 30 minutes to eat, chewing food very well, and that should be strongly demonstrated. For those patients that do have history of previous bezoar formation, they might need to avoid foods that pose a higher risk. Now, switching gears to bowel changes. Now, when you look at different bowel changes that happen after bariatric surgery, we've got two components, right? The diarrhea or the constipation. And diarrhea can be linked to the lactose intolerance, which we see oftentimes in any kind of GI surgery, even if a patient wasn't lactose intolerant before. It could be the dumping syndrome, could be bacterial overgrowth, or maybe eating mechanics. Perhaps they're eating and drinking together. Constipation, on the other hand, we're seeing because patients are having poor fiber intake, poor fluid intake, because they're having a hard time drinking their 64 ounces of fluid. They're on a high protein diet and supplements, and they have inadequate exercise. As a matter of fact, research shows that about 75% of patients that have bariatric surgery will report some sort of change in bowel habit. So what I find in my practice is that it's actually constipation that's actually reported as the most complaint when it comes to bowel changes. And we can see through the literature that unfortunately dietary fiber intake is very low, and it's low even before surgery. And the one thing that we just have to remember after talking about bezoar is that we want to encourage fiber intake, but we also have to encourage which fiber. Remember, there are different types of fiber, the insoluble fiber and the soluble fiber. The insoluble fiber really doesn't dissolve in water. That's that stringy, bulky roughage, and patients would really have to chew very, very well. I'm very cautious, especially in my gastric bypasses. I don't want anything to get stuck in the anastomosis. I do prefer soluble fiber. They still have to chew well, but that has a better chance of getting through the intestinal tract. And these are just some amounts of fiber in food. And what's nice about this is that we can kind of kill two birds with one stone. You can help them with vegetarian protein sources as well as increase fiber. And one of my favorite sources of fiber would be fiber that's found in a type of resistant starch. A resistant starch actually resists digestion in the tract, but it leads to such healthy intestinal bowel movements. So anything that's very starchy, like the plantains, the bananas, the whole grains, the legumes. I have my patients have lentils and legumes pretty much early in their postoperative period. I have them start that at about 2 weeks post-op, and that really helps with the bowel movements and prevention of constipation. The other thing we can't forget is fluid intake. The goal is to consume about 64 to 72 ounces of caffeine-free, non-carbonation, alcohol-free fluid. We do have to teach them how to drink slowly and perhaps give them strategies to increase their fluid intake. Be very wary of fiber supplementation, especially the bulking agents. We don't want to create a bezoar. So take to practice guidance on constipation, educate the patients that bowel habit changes and temporary constipation is an anticipated occurrence, help them to alleviate symptoms by increasing fluids, high fiber foods, exercise. Definitely have them set time for bathroom breaks. Don't ignore the urge to go. Fiber supplements, use with caution, and perhaps probiotics. Now, switching gears a little bit, we know that bariatric surgery can pose a risk of vitamin and mineral deficiencies depending upon which procedure. With this beautiful publication, the thing that shocked me a little bit was the results showed that lifelong vitamin mineral supplementation, iron, vitamin D, calcium, and B12 was actually not recommended 100% exclusively across the board by the surgeons. So that makes me a little nervous. Perhaps that's contributing to some of the deficiencies that we're seeing. And of course, with vitamin deficiencies, we're going to see deficiency diseases that we should be preventing, such as Wernicke's encephalopathy, metabolic bone disease, anemia. So these are the things that we're seeing. We have so many different practice guidelines out there that give us, the nutritionists and the team, the guidance on what we should be recommending to our patients. I'm proud to say that I was an author on the 2016 guidelines. So these guidelines should be part of your library. And this is just a summary right here of what we should be recommending to prevent the disease. So just to summarize, this is what I actually recommend to my patient: a daily adult multivitamin, and I do prefer a bariatric formulary if you're able to have access to that, because they do have higher doses of the nutrients that they need. I do recommend a B complex with thiamine, a B12, an elemental iron, calcium, and vitamin D. But more importantly, have these patients periodically get their labs tested so these dosages and vitamins and minerals can be changed in terms of dosages. And last but not least, I just want to mention a little bit about sarcopenia. We do see this just because still the literature shows that one of the hardest things for our patients to get is enough protein. When you look at the requirements, we're looking at about 60 to 120 grams per day recommended, depending upon, again, the type of surgery. That is very difficult for our patients to get. It's something that we really have to educate our patients on, but also keep in mind the type of protein you're recommending. When you look at different types of proteins and the amino acids, I really try to recommend proteins that are high in leucine. Leucine is a branch chain amino acid that is shown to accelerate muscle growth. And even if you have some vegetarian patients, we've got the soybeans, you've got the tofu, and you've got the beans, the nuts and seeds that are very high in leucine, which can contribute to muscle mass. Also, if they're going to allow for dairy product, or they're allowing muscle proteins, whey protein is actually very absorbable, especially the whey protein isolate, to help build those muscles. So this is my minimal recommendation to prevent sarcopenia and excessive lean body mass loss. We're going to recommend at minimum 60 to 80 grams of protein for women, 80 to 100 grams for men. Individualize the assessment up to 2.1 grams per kilogram of body weight. Don't forget to add good carbohydrates, because carbohydrates will spare the muscle as well. So you might as well kill two birds with one stone and recommend the legumes and the resistant starch, because that can also help the bowels. Always advise the patient about decreasing that sugar intake. We don't want to induce that dumping syndrome. And you also want to include good saturated fats as well. So what's the take to practice? Well, metabolic bariatric surgery is a wonderful surgery, but it certainly isn't without its nutritional risk. Patients should be optimized preoperatively and then intensely followed up postoperatively. We should work as a team. I hope you have a dietitian on your team. Stronger focus on preoperative and postoperative nutrition assessment and education should be the focus. We should have an individualized, patient-centered approach to bariatric nutrition, utilizing evidence-based and experiential practice. And of course, interdisciplinary collaboration is the way to go. I hope you have a registered dietitian on your team. And I know I talk really fast. We have some additional references there. And that's me. So I think I made it on time. As a matter of fact, I think I was ahead of time. So any questions for me?
Brilliant. That was a fantastic talk by you. And
Thank you.
Thank you for being here at this odd hour.
My pleasure.
the host has taken off my video, so you can hear me, but you can't see me.
Okay.
How do you deal with patients who have all sorts of idiosyncrasies about food and likes and dislikes?
Sure.
You are giving them the right recommendation, but how resistance from the patients to ensure that they get the proper nutrition and supplements?
Oh, thank you so much for that question. I think really the success is how we work together. It's building the relationship with that patient so they feel very comfortable with talking to you about what they like and what they don't like. And then you're giving them guidance, you're facilitating. If you can actually explain to them the difference between doing A, which could harm them, and doing B, which could help them, most patients want to do things that will help them. If it goes beyond my capability of helping them as a dietitian, we're lucky enough to work with a team. So you have a psychologist, you have the surgeon, you have the doctor. So we're all working together to help the patients benefit.
Thank you very much for that. Unfortunately, we are short of time, so we are going to have to move on. But
Okay.
we hope you have a good night's rest. And
Thank you so
for
much.
that presentation.
Congratulations on your symposium.
Thank you for logging in, and thank you for your talk, Lillian.